From Microbe TV, this is Infectious Disease Puscast episode 63, recorded on September 13, 2024. Hello, everyone. I'm Daniel Griffin, and joining me today is the very busy Sara Dong.
Hey everyone, I'm Sara. Welcome to another Puscast. References, as always, are available in our show notes at microbe.tv, the home of our growing multimedia empire. Someone pointed out to me that it's Friday the 13th. It didn't even register. So for all you,
is that why you moved it, just to lace us all with bad luck?
Yeah, exactly.
Well, so you're busy. You're on the wards doing consults and everything right now.
Yes, and for everyone who's listening, I asked for an emergency move to a different day because I was a little too slow seeing all my patients. So thank you guys for accommodating.
It's really a challenge, right? Because, part of our job, right, is the day-to-day face-to-face. But I think also part of our job, is what you and I do very publicly, which is, keep up on the literature, keep up on the changes, because, infectious disease is it's actually a fast-growing, fast-changing field. I mean, I was listening to some of the RSV things lately. There's some new antifungal agents with different mechanisms. Maybe it'll be something that targets chitin that we have to learn about next. And so part of our job is actually, after hours, just learning what we need to know so that when we get in the trenches, we're up to date.
Yeah. And double checking that what you think you knew is still the same. So I feel like I'm always double checking myself.
That's interesting, because I'm preparing to retake my boards, and I realize like every day I always, check, today I was starting a patient on treatment for septic joint, and of course I look at, okay, this is what I think the duration should be, but let me look and see if there's, what are the latest studies, and, always trying to stay up to date. So.
Yeah.
All right, let's get into it, right?
Yeah. Puscast is a review of the ID literature for the last 2 weeks that we found interesting or entertaining. So on to the literature, shall we?
All right. So viral, remember to listen to This Week in Virology. And I'm going to start us off with the article, Post-Acute Sequelae of COVID, PASC or Long COVID, an evidence-based approach published in Open Forum Infectious Disease. And there's no notes. Oh my gosh, what am I going to say? Well, I'm the author of this publication, so I'm quite familiar with what it has to say. And this is it's quite an opus. It is open access, so everyone can read this. I think we're going to send out a press release later today when I got a chance to edit that. But this is so it's an 8,000 plus word article in a journal that limits the articles to 3,000 words or less. And it starts off with a little bit of an overview, talking about the terminology. And then what it really gets into is the different phenotypes, also the different presentations that we might see. So, the neurological, the GI, the immune, the allergic. And then I think really it is really geared to a handbook for you as a patient or you as a clinician. What are the blood tests that you might want to draw up front? What are the physiological tests that you might want to consider? So it's like the Nasoline test and actually explains how to do that. The pseudomotor test explains what even is that, the sweating test, how to get that ordered for your patient, Holters, EKGs, other things. And then really probably the most important is actual evidence-based, how do we prevent people from getting long COVID? And we just presented another paper that'll be, on This Week in Virology, probably already released by the time we discuss this, but vaccinations preventing long COVID, early antiviral therapy preventing long COVID, a few other things, and then a list based upon presentation and phenotype, different evidence-based therapeutics. So we discussed vaccine, not only as prevention, but actually as therapeutic. We discussed melatonin, the bifidobacterium probiotics, and then some of the others, including for certain phenotypes, the antihistamines, the N-acetylcysteine, some of the preliminary stuff on the nattokinase and some of the others. So really gives you a list of things for you and your patient to work through as far as the diagnostic testing that may be consistent with this because there's a lot of dismissiveness out there. It's nice to have, if you can get it, some objective findings that are consistent and supportive of the diagnosis, and then really a number of things to try because we can help these folks get better.
Great. I haven't saved. I haven't gone through it yet, but I immediately saved it because I need a review. Well, this next one I pulled from the New England Journal of Medicine, a new orthoneurovirus associated with human febrile illness. I don't know how close I was on that one.
I think that's okay. I think Vincent was telling me that was a good way to pronounce it.
So this publication describes a previously unknown orthoneurovirus, which was named wetland virus, abbreviated WELV. Acute infection was identified in 17 patients from an area, and I actually included their figure 1 of the geographic distribution. So part of Mongolia, and then a couple areas in China, Heilongjiang, Jilin, and Liaoning, China. So they give a description on the map and show kind of where the cases were. The patients, from their clinical standpoint, had pretty nonspecific symptoms: fever, dizziness, headache, malaise, myalgias, back pain. There was one patient who did have neurologic symptoms. And in the animal studies that were included in this paper, there were pathologic changes in the brains of infected mice. So just showing that this could be something that can be potentially neuroinvasive. Some of the common lab findings were leukopenia, thrombocytopenia, elevated LDH. And then as part of this, they also looked at where the viral RNA was circulating elsewhere. So they identified this virus in 5 tick species and in animals that live up there in Northeast China. The sheep, horses, pigs. And I also included a little picture of a transbical zoocore, which is it's kind of like a little mole rat. I guess it's cute. I actually didn't know anything about that animal. So I think there have already been some publications on this virus, but this is sort of like a very comprehensive look at all the information that they've gathered from the patient cases and the animal studies and looking for where the RNA was found. So a really nice overview and something that folks will have to think about, particularly if patients have been in that area of Northeast China, which if you're not as familiar with China, it's like northeast even of Beijing. So.
Okay. Yeah, I think Vincent and I discussed a little bit of this, and of course it rolls off his tongue, orthoneurovirus. I'm like, oh gosh, I was struggling. But wetland virus, kudos to naming it something that I'll actually remember. Oh, wetland virus, that will stick in my brain.
I need to just speak confidently and quickly because people will just believe me if I do that. The problem is I hesitated. I worried too much.
All right. The article, and this I cover actually on This Week in Virology as well, because I really like this article. But farmed fur animals harbor viruses with zoonotic spillover potential, published in Nature. So again, we're going to see a map of China, but here these investigators perform single sample metatranscriptomic sequencing of internal tissues from 461 individual fur animals that were found dead due to disease. So basically, they took the innards of some dead animals and they found, are you ready for this? 125 virus species, including 36 that were novel and 39 at potentially high risk of cross-species transmission, including zoonotic spillover. So what type of viruses do we think they found? Hopefully people are speculating. They identified 7 species of coronaviruses and documented the cross-species transmission of a novel canine respiratory coronavirus to raccoon dogs and bat HKU5-like coronaviruses to mink. and these were present at high abundance in lung tissues. Three subtypes of what's the next one on our big list? Influenza A virus, so H1N2, H5N6, and H6N2. What is it? 16 H's and 9 N's out there that we have to worry about. But fortunately, in humans, we don't have to memorize quite that many. But these were detected in the lungs of guinea pig, mink, muskrat, respectively. Multiple known zoonotic viruses, such as the Japanese encephalitis virus, the mammalian orthoreovirus, were found in guinea pigs. Raccoon dogs and mink carried the highest number of potentially high-risk viruses. And then they go on to mention some other families commonly infected multiple hosts. So we have a nice map. They even got some cute little pictures, right, of the animals involved. They're very cute. So what are the takeaways? What are we talking about here? So I think the big point here is that when you actually go out and look at these animals that are being farmed for fur, that actually people are interacting with them on a regular basis, and they're not necessarily all dressed up and wearing the appropriate garb as one probably is supposed to be doing when they're farming these animals. But there's a lot of viruses out there just waiting to cross on over. We've been warning about the possibility of a coronavirus zoonoses for decades. Oh my gosh, we just had one. We've been warning for decades about influenza A zoonoses. And I was listening to a lecture today, and basically all influenza are bird flus, right? It's just that's where they normally reside. So they all are, intrinsically zoonoses. So really important that people do this research and that we're ready for these upcoming zoonotic pandemics that are probably going to happen. Just a question of when, unfortunately.
Yeah. For our next paper, I pulled this from Transplant Infectious Disease, a randomized placebo-controlled dose escalation phase 1 and 2 multicenter trial of low-dose cidofovir for BK polyomavirus nephropathy. So, as the title describes, this is randomized multicenter double-blind placebo-controlled sequential dose escalation trial made to evaluate the safety, tolerability, and efficacy of IV cidofovir in adult renal transplant recipients with newly diagnosed BK nephropathy. So the original study plan was to have 3 dose cohorts, so 0.25, 0.5, and then 1 milligram per kilogram, that they would receive 4 doses on days 0, 7, 21, and 35. And they were hoping to have 12 patients in each of the cohorts. Due to slow recruitment, the enrollment was terminated midway through cohort 2, so the 0.5 mg per kg dosing. So there are no patients in the study in the 1 mg per kg group. And then I think the other big question that we think about for these studies, what did they do for reduction in immunosuppression? It was at the discretion of the transplant team, but they did provide some information on what's in their general protocol recommendations. So the low-dose cidofovir in this relatively small group was safe and tolerated, but there was no significant effect on the BK DNA levels in urine or blood. There isn't a clear sort of expected decrease in BK load that we know of or some specific virologic endpoint, but I think most of us would think that an effective antiviral is likely to change your viral loads. So we don't know from this if higher doses of cidofovir would have helped, if it would have been toxic, but I pulled this because it's the only randomized placebo-controlled trial of cidofovir there is out there. So kudos to the authors for working on this, and hopefully in transplant we'll get more studies like this.
Yeah, it's sort of disappointing that we're not seeing a little bit more encouraging data. I mean, I think of cidofovir as sort of a potentially broad spectrum antiviral based on its mechanism of action. But yeah, not unfortunately seeing much here. All right, briefly, the article, a cross-sectional evaluation of the virtual outpatient management of people with Mpox, published in Open Forum Infectious Disease. You notice how many articles we pull from that august journal? That is a great journal. And it's open access. Everyone can read the articles. Well, This is a description of the successful use of telehealth to manage Mpox. Here, among confirmed cases, and then we've got an N of 221, 86% 20% were managed exclusively on the virtual ward. So I like the way this virtual ward, right? The patients out there being seen just by telehealth. The other 14% actually required admission. And how did they do? Well, this was successful. Treatment for concomitant sexually transmitted infections was provided to a quarter of the patients, 25%. Antibiotics for other infective complications, 16%. They address symptomatic relief, 27%. And they conclude, and I have to agree, that this virtual ward model facilitated safe and holistic outpatient management of mpox while minimizing admissions. Now, this is actually something we did quite a bit here in the New York area, where we saw, hundreds of cases. And so, we're seeing them in this whole tri-state area. A lot of them are be seeing initially in urgent cares. When we were moving them to receiving Tecovirimat, we'd reach out to my buddy Jason Zucker. He would arrange, and actually for that protocol for the STOMP trial, there would be one in-person visit. But a lot of people, we decided that they didn't necessarily need to be enrolled there. But yeah, so this was really a great way of safely managing folks without, concerns about transmission, about, not just to providers, but even to, unnecessary hospitalization. So really, telehealth was used to great extent and continues to be used to great extent for COVID-19. So just a great model for this and future outbreak responses.
I think this is wrapping up our viral section. I pulled a paper from JID, A Decade of Chronic Norovirus Infection Surveillance at the NIH Clinical Research Center, Clinical Characteristics, Molecular Epidemiology, and Replication. So this is a cohort of immunocompromised patients that are followed at NIH, and they took a detailed look at norovirus from this time period of 2010 to 2022. There were 88 clinical research participants, and chronic infection was defined as PCR detection at least twice for 2 or more consecutive months. 39 of the 88 patients provided multiple stool samples over time and shed virus anywhere from 69 to 2,531 days, with a median of 485 days. So over a year. I should have converted it to years for ease of listening. So all of these were immunocompromised hosts. Most had inborn errors of immunity or malignancy. There was a very high mortality in the cohort. About half of the patients were deceased at the time of the last follow-up. And as for those types of defects, many had primary B cell defects like CVID, and the majority had some degree of T cell deficiency. So they also looked at, the load of norovirus shedding and the genetic diversity. They had 5 distinct variants identified and, indicated some of that shift in the variants over time. I thought it was also interesting that the majority of the clinical specimens did not show evidence of replication in those, testing sort of optimal environment. So it just goes to show that the success of it replicating in the patient is not surprisingly a combination of like viral and likely host factors. But these chronic norovirus infections are so challenging. So I thought it was really interesting to see, obviously a very unique population that is followed there at NIH, but I think at least gives us a little bit of insight into our other immunocompromised patients that you might see at your own center.
All right, and moving into bacterial, be sure to listen to This Week in Microbiology. Start off with the article Lyme, or I guess this is really more of an announcement. Lyme Immunoblot receives FDA clearance. I'm not sure how this new test will roll out and how people will start ordering this over prior tests, but we read here that the ID DART Lyme IgG Immunoblot Kit is a standalone test for the detection of IgG antibodies against Borrelia causing Lyme disease. So this ID DART Immunoblot Kit features, are you ready for this? 31 Lyme antigen bands. I'm already like, oh my gosh, which are more antigen bands than any other Lyme immunoblot test on the market. Moreover, it's the only immunoblot that includes OSPA P31 and OSB P34. We read that the inclusion of 31 antigens improves the sensitivity of the detection of Lyme-specific IgG antibodies, which in turn will improve the sensitivity of the diagnosis of Lyme disease in suspected patients without sacrificing specificity. What do you think? What do you think? Are you sold, Sara?
I don't know enough to interpret.
Yeah, I don't really know if I know enough yet. I'm sort of curious to see where this fits in.
Yeah. For the next one, I pulled this from JPIDS, the utilization of echocardiography. I was going to say echocardiogram in children with Staph aureus bacteremia. I am pulling this and had to highlight it because I got to meet and hear Richard's talk for the ID Week coaching program. So I want to give a shout out both to the coaching program and also to getting to hear his talk a little bit early and at the conference. So he did a really great job. I think this actually is a question that comes up not infrequently on pediatric ID service. And I think as a med-peds person, I see the other side for taking care of adults, where there's no question, about a quarter of adults with Staph aureus bacteremia are going to have endocarditis. We get that echo. But do we really need routine echoes in children who have Staph aureus bacteremia? It's estimated that the rate of endocarditis is probably, 10%-ish or less. So in this study, they had 331 pediatric Staph aureus bacteremia cases at Texas Children's. 140 of 331, or 42%, underwent an echo. And of those 140, 9 of them, or 6%, were diagnosed with endocarditis. So none of those 58% of patients who did not have an echo and received a median of 15 days of antibiotics, none of them came back to care or had endocarditis that developed. And none of the endocarditis identified by echo was seen in otherwise healthy children. These were kids who had congenital heart disease, or the other thing that stood out is if someone had prolonged bacteremia. So those two things, congenital heart disease and prolonged bacteremia, were independently associated with echo positive endocarditis. And so they advocate for performing echo or limiting it to specific children who have risk factors like this. So congenital heart disease or bacteremia for 3 or more days, which I think makes sense and kind of fits with what I feel like I've seen in practice. But great job, Richard.
All right. Yeah, I sort of wonder about a distinction between persistent and prolonged, right? Because we've now, persistent is more than 24 hours on effective bacterial agents or antimicrobial therapy, and should then prolonged, and maybe there's some way to sort of even updating those Duke criteria even a little bit more. But okay. The article, Duration of Antibiotic Therapy for Multidrug Resistant Pseudomonas aeruginosa Pneumonia is Shorter, Truly Better. This was published in BMC Infectious Diseases. And I shall say the 2016 IDSA guideline recommends a treatment duration of at least 7 days for hospital-acquired ventilator-associated pneumonia. The limited literature has demonstrated higher rates of occurrence for non-glucose fermenting gram-negative bacilli with short course therapy, raising the concern of optimal treatment duration for these pathogens. So that's background. So therefore, this study aimed to compare the outcomes for patients receiving shorter therapy treatment. So that's less than or equal to 8 days. That'd be 7 days, basically, versus longer treatment greater than 8 days, sort of the 8-day week for the treatment of multidrug resistant MDR Pseudomonas pneumonia. So these are the results of a single center retrospective cohort study conducted to evaluate adult patients receiving an antimicrobial regimen with activity against MDR, Pseudomonas aeruginosa, in respiratory culture between 2017 and 2020 for a minimum of 6 consecutive days. They have some exclusion criteria And of the 427 patients with MDR Pseudomonas aeruginosa respiratory isolates, 85 were included. Baseline characteristics were similar among the groups, median age of 65.5 years. Roughly 75% had what they defined as ventilator-associated pneumonia, compared to those who received less than or equal to 8 days of therapy. No differences were seen for clinical success in patients treated for more than 8 days. Now, 80% versus 65.5%. The number of 30-day and 90-day, or numbers for 90-day and 30-day in-hospital mortality, 30-day relapse, and other secondary outcomes did not significantly differ among the treatment groups. So they bring it all together by basically saying prolonged treatment duration beyond 8 days did not improve patient outcomes for MDR P aeruginosa, healthcare-associated or ventilator-associated pneumonia. So that will put that all to rest. We now know what to do. No one will ever do more
We haven't
than...
talked about Pseudomonas pneumonia in a little while. I feel like there was a string of papers a little while back that we were covering. So,
all right, well, I've got another, and this is, oh my gosh, short versus long antibiotic duration in strep pneumonia bacteremia, published in Open Forum Infectious Disease. Just when I thought I knew what to do there. These are the results of a retrospective single-center cohort study that assessed hospitalized patients with S. pneumonia positive blood cultures. So this is strep pneumonia bacteremia, who received active antibiotics within 48 hours of the first positive blood culture collection. So someone's awake, achieved clinical stability by 10 of the first positive blood culture collection. A total of 162 patients were included, with 51 patients in the short and 111 in the long duration group. Pneumonia was the suspected source of bacteremia in over 90% of the patients, right? So this is really strep pneumonia with bacteremia. Rates of clinical failure were not significantly different between the two groups. So patients received a median antibiotic course of 7 days in the short group compared to 14 days in the long group. That's what I was taught to do. However, there was no significant difference when you looked at median hospital length of stay, median ICU length of stay, or even rate of complications such as C. diff infection. So it looks like 7 days is just as good as 14, at least in this particular study.
mm-hmm. Yeah, I'm trying to think. I feel like I've probably been doing 14 days.
Yeah,
So.
I was still taught that, but I have to admit, I'll often at day 7 switch to oral, and then maybe that oral is just like useless.
Well, I will take us into our fungal section. As always, we'll plug that we are anxiously awaiting the next last season.
Pablo, come on, what's going on?
So I have an article here, Incidence and Risk Factors for Invasive Fungal Infections in Patients Initiating TNF-alpha Inhibitors for Inflammatory Bowel Disease and Rheumatoid Arthritis, published in CID. So TNF-alpha inhibitors include things like adalimumab, certolizumab, etanercept, infliximab, which I think a lot of us are sort of increasingly seeing, complications from those. So this paper took a look at data from commercial claims database information in the US and used ICD-10 codes to find patients with IBD or RA and see if they had filled an outpatient prescription for a TNF-alpha inhibitor. And then they also used ICD-10 codes to try and identify an invasive fungal infection diagnosis. They found of about 13,000 patients with IBD starting a TNF-alpha inhibitor, the IFI incidence was 3.3 per 1,000 person years. The median time from prescription of the TNF-alpha inhibitor, to diagnosis was 134 days. Histoplasma was the most common. In their other group of about 20,000 patients with RA who started a new TNF-alpha inhibitor, the IFI incidence was 2.8 per 1,000 person years. That median interval from prescription to diagnosis was 162 days, and histoplasma was again the most common infection. So fewer than 0.5% of patients developed an IFI within 1 year of initiating TNF alpha inhibitor. It was slightly higher in those who were on the medication for IBD versus rheumatoid arthritis. There were some regional differences, obviously in places that have coccidioides, that was more common. And I think that, there's limited information based on how the data is collected on other things that increase risk, like their other immunosuppression. If they had a transplant, it did seem like they were more likely to have infections. I don't know that I need to say a ton about the limitations of using this type of data and ICD-10 codes. I still think there's a lot of unanswered questions. Does the dosing matter? What were their regimens? What about those patients who don't get commercial insurance? Honestly, what happens past 1 year? We know that there's sort of that, we talk about the net state and kind of cumulative effect of being on these medications. But I still think it's a starting place and kind of a number that you can, start. And if people ask, present, but, still a lot more to learn related to the topic.
Okay. And I remember this really nice, what is that, infographic, or what do they call this?
Visual
Graphical
abstract.
abstract.
Yeah,
How
yeah.
about that? Yeah. All right. And one I throwing in here in parasitic, but if you really want a deep dive into this paper, we have an entire episode on This Week in Parasitism where we discuss the paper. Intestinal helminth infection impairs vaccine-induced T-cell responses and protection against SARS-CoV-2 in mice. And so sort of an interesting sort of note on when you're looking at vaccine responses in different populations, particularly if you're looking at how well vaccines may or may not work in certain areas where there's a high parasite load in the population, you might actually find that intestinal helminth infection impairs your vaccine responses. So for a deep dive, intestinal helminth infection impairs vaccine-induced T-cell responses and protection against SARS-CoV-2 in mice was published in Science Translational Medicine. All right. And I think, let's see, we've got a couple here in miscellaneous to finish things off. So I will, my last article, the article Successful Treatment of Refractory Cutaneous Protothecosis with MAT 2203, an oral lipid nanocrystal formulation of amphotericin B, was published in Open Forum Infectious Disease. So Prototheca wicker hamii. Do you like the way I pulled that off? It's a type of green algae that is associated with plants, fresh and seawater, as well as the soil. And it actually is a rare cause of cutaneous and systemic infection. I don't think I've ever treated anyone with an algal infection, right?
Yeah.
And here they say this requires long treatment courses with potentially toxic medications. So here the authors describe a patient with cutaneous protothecosis, refractory to triazole monotherapy, who experienced clinical and radiographic improvement with the novel oral lipid nanocrystal formulation of amphotericin B without experiencing toxicity. There's actually some really nice photos, right, of the clinical presentation, the before and after photos, even some under the microscope shots. So really, really, something I probably wouldn't have thought about, but I guess would have gotten the excited call from the micro lab.
And I will close us out with one more paper from CID, the impact of infectious diseases scholarly mentorship on subsequent ID fellowship application. This took a look at research and case reports from Brooke Army Medical Center, so they would have like a senior ID author and then either a medical student or resident first author. So they had about 16 faculty and then 35 med student and student and resident research projects and 26 case reports. They found that mentoring these learners in research was associated with greater rates of ID fellowship application, 41%, compared to case reports, which was 4%. So those that had published or presented their research projects, that was associated with increased application rates. So I think this is just a really nice reminder about how valuable those programs are that help our med students and residents present their research, making sure that they're available and prioritized. And, you can't tell from this how many of these trainees were already sort of self-selected, meaning like maybe they already knew they were doing ID or had another mentor, or, how much, if any, impact there is that this is specifically a military program versus a civilian program. But I don't know. I think it makes sense and provides some encouragement that building connections with trainees is obviously very valuable. But I think maybe just, it's hard because I think for case reports, if you're mentoring someone, you probably are more involved. If you're doing a research project, maybe it's more longitudinal. So I think it makes sense that some of these research projects stood out in particular, and that those folks ended up going into ID. So anywho, I just thought we'd end on a good note. Seek out those mentorship projects. And that's all I got. So that brings us to the end of this podcast. As always, the references for this show are available at microbe.tv, the home of our growing multimedia empire.
You can find the Infectious Disease Puscast at Apple Podcasts. Also, microbe.tv/Puscast, or grab it with your favorite podcatcher. We love to get your questions, comments, and paper suggestions. So, shamelessly send your paper our way if you would like it featured. Send them to puscast@microbe.tv. If you like what we do or you just want us to keep doing it, consider supporting the science shows of Microbe TV at microbe.tv/contribute, or Parasites Without Borders at parasiteswithoutborders.com. Click on that donate button.
I'm Sara Dong. You can find me at swindong or at federalpodcast.com.
I'm Daniel Griffin, and you can find me at Columbia University Irving Medical Center or at parasiteswithoutborders.com, as well as on, this podcast and the other podcast, This Week in Parasitism and This Week in Virology Clinical Updates. And as always, thank you for this most interesting consultation and allowing us to participate in the care of this most difficult and challenging case. We shall continue to follow along with you. Thank you, and dictation, and goodbye.
Thanks for listening. We'll be back in 2 weeks. Another Puscast is infectious.